Yeah, we are live, sir.
Oh, wonderful. And they can see me now, right?
Yeah.
Still?
No. Yeah.
All right, wonderful. Good morning, everyone. This is Haresh Sampath Kumar. I'm one of the co-founders of JH Rehabilitation. I welcome you all to day 2 of our webinar series that is titled An Update on Why and How the Rehab Community Should Take Care of the COVID-19 Patients. Today, we have 3 speakers from the specialty of physical therapy, and they are part of Mount Sinai Hospital in New York. With their extensive experience in taking care of COVID-19 patients, we couldn't find any better speakers to talk on this topic. So the subtopic for today would be physical impairments in post-COVID patients and strategies for intervention. So as I said, we have 3 speakers today. So the first speaker is William Weinrock. Is master in clinic. Is a master clinical physical therapist at the Mount Sinai Hospital. Dr. Weinrock has worked on the model systems, spinal cord injury, acute rehabilitation unit for 10 years. In addition to usual patient care, Dr. Weinrock participates in spinal cord injury research with specialty in exoskeletons. He has also received level 2 certification in exoskeleton, and is also certified to use the ReWalk, which is the other exoskeleton. In addition to spinal cord injury rehab, Dr. Weinrock also provides cross coverage on the model systems traumatic brain injury unit and is also a certified brain injury specialist. And we have the second speaker, that is Christina Nocella. She's a graduate of the Simmons College. She's been practicing in acute care setting for 10 years, with 9 of those years being in the ICU. Her research regarding use of neurostimulants in acute stroke has recently been published in the Journal of Neurocritical Care, and she's also led multiple early mobility initiatives. She's currently practicing in the cardiothoracic and cardiac intensive care units at the Mount Sinai Hospital. And lastly, we have Erin Hopkins. She's a graduate of SUNY Downstate Medical Center. She comes to the field of physical therapy from a career in dance and a performer, choreographer, and dance educator. She's currently practicing at Mount Sinai Hospital as part of the cardiothoracic physical therapy team. As you can see, our speakers come from various backgrounds. Now, once the talk is over, we'll take questions. However, you don't have to wait until the talk is over to ask questions. You can post your questions on the chat section on the right-hand side of the YouTube screen. And at the end of the talk, I will be presenting the question to the speakers, and we'll have a question and answer session at the end. So without any further delay, I would like to introduce Dr. William Weinrock to proceed with the presentation. And also, I thank both the speakers for agreeing to participate in the talk and for the audience for attending this talk. Thank you.
Thank you for having us.
Yeah, now.
Okay, so this morning, as we were introduced, we will be presenting on the physical impairments in the post-COVID-19 patient population and strategies for intervention. Through the presentation, and we're going to achieve that through the presentation of 2 case studies. And as we're talking, the objectives we'd like for you to keep in mind are to identify some common post-COVID-19 physical impairments, and identify strategies for interventions for those impairments, and then also to identify common barriers and challenges to treatment. These two case studies are quite different, but I think you'll find quite a few similarities. So William is going to start us off with a presentation of an post-COVID adult.
Hi, everyone. Good morning or afternoon, depending on your time zone. So our case study is going to begin with a patient who is a 62-year-old African-American female. You'll note that her prior medical history contains a lot of the comorbidities that have been associated with greater COVID-19 severity when infected. She has morbid obesity, weighing over 350 pounds, severe asthma, obstructive sleep apnea and a CPAP at home, a reduced ejection fracture of 47%, AFib, type 2 diabetes, along with lymphedema. Socially, she lives alone in an elevator building. Prior to getting infected, she was a household ambulator with a single point cane or no device within the home. Her community ambulation was limited with a bariatric rollator, and she was limited by overall fatigue and shortness of breath. She was independent with activities of daily living, such as getting herself dressed and bathed and groomed, but she required assistance with things such as shopping, cooking, and cleaning. Also, she was still working at an insurance company, which also provided her health insurance, which is notable for situations later in this study. So on April 8th, she presented to Mount Sinai emergency room with a non-productive cough, about 1 to 3 episodes of watery diarrhea, and known COVID exposure from her niece who works in a nursing home. She developed acute hypoxic respiratory failure requiring BiPAP. While at Mount Sinai, she was there for 137 days. You'll see that for PT services, she had 36 sessions at 87-day length of stay, and she was in acute inpatient rehab for 50 days. As for OT services, on the acute care side, she received an evaluation and 1 treatment session, both of which required for her to qualify for inpatient rehab. The interesting thing is a normal inpatient length of stay is around 2 to 3 weeks for somebody who presented with her admitting diagnosis. So the patient was eval'd in acute care on April 30th, which was 3 weeks after admission, which was when she was deemed medically stable for evaluations. She was alert and oriented ×3 and able to follow multiple step commands. Her range of motion was within functional limits, but some of her lower extremity range of motion was limited secondary to the lymphedema. Her upper extremity strength was at least 3+ out of 5, so pretty good, but her lower extremity strength was definitely weak at the hip and the knee. Sensation, proprioception, muscle tone, and coordination were all intact. On the first day, the patient deferred mobility secondary to reporting dyspnea, which was a reoccurring theme throughout most of her 137 day. On the second day, the patient was able to perform bed mobility, but required max assistance of 2. So more functional deficits that were noted on the initial evaluation were cognitive and motor planning. There was noted reduced insight into the patient's medical condition, especially pertaining to the amount of oxygen that she required. She also reported some cognitive defects such as a foggy brain and some memory issues. And then her motor planning was pretty impaired, requiring constant verbal cueing for sequencing on tasks, a lot of distractibility, and then poor carryover from one session to the next. Also of note, as I mentioned earlier, her dyspnea on exertion as reported. Her oxygen saturation was usually pretty good, over 90%, either with the nasal cannula or the non-rebreather mask. And she didn't demonstrate any increased respiratory rate or effortful breathing, however, constantly required upgrades in oxygen delivery secondary to discomfort. So you'll note some of the interventions in acute care were a written home exercise program, which only had limited success secondary to poor compliance, and that involved a lot of lower extremity thorax in bed. And then functional mobility, which was key throughout the patient's entire treatment. The picture is of Sarah Plus, which was key in the patient's early mobility, helping the patient perform sit to stands edge of bed with a lot of assistance from the therapists. Other things that they did were neuromuscular re-education, such as sitting balance and standing balance, a lot of guided imagery, a lot of psychosocial management, patient education, all these things to help the patient understand her diagnosis, understand her potential, and understand what had to be done in order to reach her goals. Lastly, the patient did not have a lot of faith in therapy in general in the beginning and always wanted extra hands on deck, and especially male nurses assistants, in order to make her feel more confident in her ability to perform tasks. On the occupational therapy side of things in acute care, they performed grooming, upper body dressing, bed level, and then all lower body dressing was dependent. The patient was dependent for all toileting, and they also worked on some static and dynamic sitting balance edge of bed. So then you can see the progression from physical therapy initial evaluation to discharge. The patient had a very slow progression overall in those 87 days. For bed mobility, she was able to decrease the number of people involved in rolling and transferring from supine to sit, but she still required maximal assistance of 2 people to transfer from sit to supine, mostly because of the lymphedema in her legs. Transfers, again, she was able to decrease 1 person, max assist of 3 to start, and then max assist of 2 sit to stand edge of bed at the end. And then you can see ambulation was only initiated on 6/28, and she performed 3 side steps. And then on discharge, the patient was able to step 6 steps forward and backward with a rollator with max assist of 2. So this particular patient is one who would normally transfer to a subacute rehab facility. Subacute rehab facility provides less therapy during the day for people who can't tolerate the 3 hours that are required by acute care, acute inpatient rehab. However, this patient did not have a subacute rehab benefit with her insurance. So at the time, the only option seemed either for the patient to go home or the patient to come to inpatient rehabilitation. Lots of work was done behind the scenes by case management and physical therapists writing letters to the insurance company in order to try and get the patient into subacute rehabilitation, but they were not on board with that plan. So as it was unsafe to send the patient home, the patient was then transferred to inpatient rehab. So on July 2nd, the evaluation was performed for the inpatient rehab facility. An evaluation is done again when the patient transfers to this unit. The patient also requires a negative test for COVID-19 prior to admission to the unit. Medically speaking, the patient was admitted under the diagnosis of critical illness myopathy, which is a general syndrome of muscle dysfunction occurring in the critically ill patient. The patient arrived with a stage 3 sacral pressure ulcer, Foley catheter. She was bowel controlled, and then the chronic lymphedema was noted in bilateral lower extremities. Her O2 requirement was on a nasal cannula between 4 to 6 liters. The oxygen saturation was within normal limits on 4 liters, but the patient would often request a bump to 6 liters, stating that she was unable to breathe despite the objective findings from the O2 saturation. So the initial evaluation of the physical therapist on acute rehab was about the same as what the patient was discharged with, max assist of 2 for bed mobility. The transfers, they performed a sliding board transfer, which required 3 persons, and the patient declined sit to stand transfers. The occupational therapy evaluation showed minimal assist for upper body bathing and dressing. independent at bed level for eating and grooming, and then dependent or max assist for lower body bathing and dressing. The toilet transfer and the tub transfer were unable to be performed at that time. In looking at this patient, we obviously wanted to get her at her prior level of function. And so our short-term goals were designed in order to ensure that she was able to be independent for activities of daily living as well as her mobility-related activities of daily life. So working on transfers and bed mobility, sitting, standing, dressing, and then progressing towards ambulation. Given the patient's body habitus, the barriers to discharge, we did a dual planning goal of having the patient be a household ambulator along with independent with wheelchair mobility. The occupational therapist long-term goals were min assist for transfers to the commode, as well as min assist for donning and doffing of pants. So like I said, some of the barriers to this goal attainment was the body mass index. The functional mobility required multiple persons to assist the patient in performing transfers and ambulation, along with specialized equipment. The patient's cardiopulmonary status and her self-limiting attitude kind of worked against each other, in that the patient required long rest breaks between each task that we performed, which ultimately slowed her progression even further. Her anxiety contributed to this as well, along with her overall deconditioning. So our interventions, like I said, also required specialized equipment. Pictured on the slide is the light gate for mobilization, which was utilized for ambulation. It was body weight support, and we also utilized the Goldman sling, which is another body weight support system. The patient has very poor endurance, requiring a wheelchair follow and extended seated rest breaks after even only ambulating a few feet. Even after performing bed mobility, the patient would often have to sit for 5 to 10 minutes edge of bed and quote unquote catch her breath in order to perform the next thing, which really limited the amount that we could accomplish in one session. We continued with more interventions such as therapeutic exercise, sitting balance, lymphedema management, a lot of psychosocial education management, and then power wheelchair mobility. So given this patient's limited ambulation status prior to admission, we explained to the patients that power wheelchair would really be the thing that would most likely maximize her independence in the community. She was very hesitant at first to even trial a power wheelchair, but ultimately was on board and trialed and liked driving a mid-wheel power wheelchair. So that was added to her equipment list, and we were able to order that for her prior to discharge. For occupational therapy, their interventions, again, really focused on a lot of function. The patient really needed that constant repetition of the functional tasks in order to gain confidence in her ability to do it, and in order to maximize her independence in the home. So they practiced dressing using a lot of adaptive equipment, progressing from supine in bed to then sitting edge of bed. With toileting, she progressed from using the indwelling catheter and dependent at bed level for bowel management to performing perianal care and clothing management on a commode using grab bars for assistance. They also focused on upper body strengthening and then endurance using the upper body arm bike. Again, occupational therapy also worked on sitting and standing balance when the patient was able to progress, and then toilet transfers, ultimately being able to use the rolling walker, and then tub transfers, which first started out as a dependent Hoyer lift transfer, and then progressed to ambulating transfers using the walker and the tub bench. Another member of our team who really added to the patient's overall success was neuropsychology. In the context of COVID-19, many patients are admitted to rehab with delirium. It's often the case following hypoxic events, ventilation, and/or sedation. Post-COVID patients have diverse presentations and cognition ranging from intact to severe impairment. With this particular patient, psychotherapy focused on providing the patient with psychoeducation about her experience, along with validating the experience of frustration around her change in functional status. They provided a space for the patient to express her feelings of sadness around her recovery, while also providing motivational interviewing to assist the patient with creating goals, both while on acute rehab and then post-discharge to aid in adjustment. So like I said, normally a patient of this nature would stay roughly 2 to 3 weeks on acute inpatient rehab. However, because this patient worked for an insurance company and that company provided her with their health insurance, she was able to appeal her discharge multiple times, ultimately extending her length of stay and therefore providing her greater independence in her functional status. The family was involved, her sister and her niece, and both were able to come in to receive family training on how to appropriately guard the patient during ambulation and other functional mobility. So on discharge clinically, her pressure injury was almost fully healed by discharge. The Foley catheter had been removed and the supplemental oxygen was no longer required at rest. We did trial no oxygen with some functional mobility, and while the patient's saturation was fine, above 95% in most instances, the patient still required 4 liters via nasal cannula, second to self-reported complaints of dyspnea. So you can see the functional status really showed a marked improvement. Bed mobility, the patient was able to get out of bed independently, but still required assistance to lift the lower extremities into bed when getting back into bed, secondary to the lymphedema. With transfers, the patient was able to stand with supervision and ambulate with the rolling walker with supervision. She ambulated up to 60 feet at best with supervision with the rolling walker and 4 liters of oxygen. And then she was able to drive the power wheelchair in the community with supervision. The occupational therapy functional status on discharge, she was supervision for grooming, setup and supervision with adaptive equipment for dressing, for toileting, supervision for clothing management and perianal care, toilet transfer, ambulating transfer with supervision, and then the tub transfer, min assist for leg management once she ambulated into the bathroom with the walker. So in summary, as I said, an 87-day length of stay in acute care, a 50-day length of stay in inpatient rehab, and a successful discharge home. I actually just spoke to the attending physician yesterday who said the patient is doing well at home. He had a visit with her. She's ambulating in the hallways without oxygen, independently, doing well, able to perform most of her ADLs independently without assistance. And then you'll note in this patient, COVID-19 definitely caused a sharp decline in the patient's functional status. The premorbid conditions likely attributed to this decline, as well as limited mobility prior to hospitalization, really exacerbated the patient's impairments as we saw in the hospital.
Great, thanks, Will. So I'm going to be presenting the second case study on an adult male with prolonged ECMO with bridge to lung transplant. So we have Mr. Z, who is a 40-year-old Latino male with no past medical history or surgical history, never a smoker. He's a very active guy, lives with his 2 sisters in Queens, enjoys playing soccer, going to the park with his family. He presented to Mount Sinai, Queens on March 31st with a fever and cough for the past week, and then an increase in shortness of breath for the past 2 days. And he was diagnosed with COVID-19. So what I'd like to do here is I'd like to just do a brief rundown of his hospital course, and then we can focus a little bit on the PT evaluation and impairments. Again, it was a pretty long and complex hospital course. So like I said, he presented March 31st to Mount Sinai, Queens with shortness of breath. He was transferred then to the Mount Sinai Hospital on April 3rd on BiPAP. BiPAP was no longer supportive enough. So on April 5th, he was intubated. And then even intubation and mechanical ventilation was not enough to support his oxygenation status. So he did require VV ECMO on April 6th, the day after he was intubated. Once again, despite the intubation and the ECMO, he still was having trouble oxygenating. And at that point, we initiated the prone protocol. On April 20th, there was noted in the chart that he had further deterioration of organ systems, central nervous system. His, again, respiratory status was declining. His vascular system was failing, and they ended up having a family meeting with his two sisters. At that point, due to the critical nature of his illness, the team had recommended vent liberation because his prognosis was so poor. However, his sisters and family decided they would like to keep pursuing all options. So it was full steam ahead with full care. Because it was anticipated that he was going to need prolonged mechanical ventilation, he was trached on the 29th. And then the April 29th through May 25th, he had multiple episodes of instability. His trach was bleeding, had a new pneumothorax, he had hemodynamic instability, and he was sedated. On the 26th of May, he started to show signs of clinical improvement. And so from the 26th of May to June 18th, there was the team was working on vent weaning and awakening. And then it wasn't until 6/18 that the PT order was placed, which was nearly 80 days later. And you can see this was his chest x-ray on presentation, which is pretty awful. And you can imagine how it progressed from there. So impairments on that June 18th initial evaluation, the patient's cognition, he was alert. He was alert and oriented ×2. Following one-step commands, though, only 50% of the time, and required extensive verbal and tactile cueing. We noted bilateral visual tracking. Our range of motion assessment showed shoulder limitations, but otherwise his upper extremities were intact range of motion wise. His lower extremities were very tight. We could only get dorsiflexion to neutral with quite a bit of pressure. And it was noted that he had significant hamstring and adductor tightness also, which came into play when we started to mobilize. Strength was difficult to assess because of his limited ability to follow commands, but we noted approximately 2 out of 5 strength in his uppers and some anti-gravity strength in his lowers, but again, assessment was limited. Neuro-wise, his motor control and coordination was limited by weakness only, but no specific coordination deficits. Tone was grossly intact, and we weren't able to accurately test sensation and proprioception secondary to cognition, but seemed intact to what we could assess. And then on evaluation, he was not cleared medically for any mobility. So he had been, per the nurses, total assist for all, been mobility. And I'll talk about his mobility as we were able to progress. Other things I'd like to just note, his skin, he did have 2 pressure areas, one on his cheek from prone positioning, and then one on his posterior occiput where they had to secure his ECMO line. And then his respiratory status at the time of evaluation, he had moderate secretion burden and was requiring frequent suctioning as his cough was relatively ineffective. And he was able to be on trach collar for the majority of the day, and then the vent resting at night. So this is a quick review of VV ECMO, and for time's sake, I will not review it, but it's here if anybody would like to go back and review But basically, VV ECMO is used in cases for respiratory support and management of hypoxia. So where we were with this patient is his lung capacity was so poor and his oxygenation status was so poor that we were unable to wean ECMO despite medical management and medical optimization. So at this point, the goal was for lung transplant, as weaning the ECMO was not a feasible option. So that led us to our big therapy goal, which was to progress this patient's functional status, ideally to ambulation, so patient can qualify for lung transplant. To qualify for lung transplant, they're looking at someone who is motivated, who can participate, and who is showing functional gain. So the biggest push was to get this gentleman to ambulate and to walk. I will note that Mount Sinai does not have a lung transplantation program, so we were looking at local programs in the area. And again, mobility on ECMO is not something that's very normal for us because we don't have this type of program. So it was a lot of learning for all of us. So because that the push was to demonstrate functional improvement and functional gain, that's where the focus of our sessions were. So we would have loved at times to spend a whole session just working on range of motion and therapeutic exercise, but where the push was to show big functional gains, we ended up spending the most of the time on functional mobility once we were cleared to do so. So I'm just going to talk about the details of his functional progression, and then I'll show you the timeline when he was able to achieve these goals. So at first, we were cleared for bed level activity only, and that was on that initial eval on 6/18. So at that point, we were working on therapeutic exercise for the upper and lower extremities. At first, he required active assist for all activity, but was able to progress at the time of discharge to all active exercise. We were also working on passive range of motion and prolonged stretching, especially to those tight shoulders, heel cords, hamstrings, and adductor muscles. Eventually, not too long after, we were cleared to attempt some edge of bed activity. So we started to work on sitting balance. And what we found, and you'll find with all of the activities, is that this patient was really posteriorly leaning, pretty retropulsive. And the reason for that was his extensive muscular tightness in his back extensor musculature, hamstrings, and then when we got to standing, his heel cords. At first, he was total assist of 2 for the physical assist, plus multiple other staff members for the line management for sitting edge of bed. And we were very much limited by his fatigue, O2 saturation, and hemodynamics. We really started off at 1 to 5 minutes of activity and were able to progress over time with improvement to, 5, 10, 15 minutes at the edge of the bed. Once he showed us that he was able to achieve sitting balance with contact guardman assist, we then started to work on sit to stand activities. So again, really hard for him to achieve that forward momentum secondary to the muscular tightness to get that upright position. He was, again, max of 2 to achieve a partial stand at first, but eventually closer to discharge, which was in August, was able to do it with contact guard assist. This patient had a lot of anxiety, and what I'd like to note for this is that we had multiple staff members around him trying to assist, it actually increased his anxiety. And once we gave him a little bit more space to try to complete the transfer as independently as he could, he then was more successful, which I found interesting. A lot of people want more assist. He wanted, more space. So once we got into standing, again, retropulsive, leaning posteriorly due to those heel cords. If we leaned him more forward, his heels were off the floor because he was so tight. We did use a rolling walker to encourage more of a forward posture. And initially we worked on just static standing, but were able to progress to dynamic standing. And once we were able to do that, we progressed to the chair. And then once we were able to achieve decent amount of time in standing, we then progressed to gait. Heel to, we noted a toe to heel pattern initially because of the heel cord tightness. And then because of the adductor tightness, he had a very scissoring gait pattern. So we had to focus a lot on widening his stance, and he really wasn't able to achieve a walk without any scissoring steps until the last week or two of his hospital stay. We were using a rolling walker. We were supporting his trunk to try to get him more anterior, and he needed a wheelchair follow with frequent seated rest breaks. And these rest breaks could be anywhere from 5 to 15 minutes, depending on his fatigue level. We started at mod assist of 2, progressed to min assist of 1 with a rolling walker, and of course, a whole team for the management of all of the lines. So this is the timeline of how he was able to achieve that. Again, for time's sake, I won't go into major details, but again, our initial evaluation was on the 18th. We progressed to standing on July 3rd. We did use the Seralift for a short time, but again, the equipment and everything made him a little bit more anxious, so we discontinued that use. And then we got to ambulating short distances, July 23rd, longer distances by discharge. And by discharge for the last 2 weeks, he was able to accomplish 50 to 60 feet of ambulation ×2 with a rolling walker and a pretty long seated rest break between each trial. And the pink boxes just show what we were working on as far as interventions to achieve each step. So our hemodynamics during these activities, I just wanted to briefly touch upon that. So he was on trach collar at 100%, but again, the oxygenation was not providing much support secondary to his poor lung capacity. It was a lot of a comfort thing for him. We had some secretion burden. His respiratory rate consistently would go from the 30s to the 40s. And his O2 saturation was the most challenging, and we would consistently desaturate to the 70s with activity. So this was a surprising number for all of us, that the doctors really provided us with the guidance of what parameters for O2 were okay. And we determined that anything in the 70s was acceptable. And if we had not set the parameter at the 70s, we would have never progressed functional mobility wise, and he would have never qualified for lung transplant. So that was something we worked closely with the physicians on. Heart rate would stay in the low 100s with activities, and with anxiety, he'd get some mild hypertension. So our barriers to treatment were, again, our O2 saturation. We had at one point a ECMO protocol that was very conservative, and we quickly abandoned that at the guidance of our physician. So we really were going to our physician every day saying, what is our O2 saturation? What are we okay with? This is what happened, and checking back in, having them present if needed for the session. Just like William's patient, anxiety was huge, a huge, huge, huge barrier. Even just the thought of walking or the thought of doing some physical activity would increase his respiratory rate, his perceived dyspnea. His respiratory rate would go up, O2 would go down, BP would increase, and he would develop this feeling of, I can't. We did end up needing to really pre-medicate him for anxiety. We did a lot of imagery, guided imagery, a lot of paced breathing and things like that to help him calm before walking. And then we would often need to use those strategies again during his seated rest break. Our sessions were obviously very dependent on his medical status. There were times where his O2 saturation would be very low, even at rest, and that was an indicator that the oxygenator needed to be exchanged. And once they did exchange that, it was a huge improvement. He had a code stroke at one point for a facial droop that never panned out to be anything. And then again, hemodynamics. The coordination of the activity for the acute care setting was a really big challenge because we needed perfusion, we needed 2 therapists, we needed the RN for line management, a PCA for a chair follow, and then intermittent physician support. So getting this team together every day was a challenge, which also added to this kind of time-consuming nature of the session. The session itself was 1 hour, then you needed 1 hour for coordination, and then sometimes multiple attempts secondary to his anxiety and his symptoms. So it was difficult to make this happen every day, and we did try to make it happen every day because, again, this is what was going to get this gentleman lungs. And then the focus on functional activities kind of limited what we were able to do. So this is the team that really worked with him. And just again, for time management, I won't go through each of this, but we had OT on board, we had speech, we were able to progress to a diet at one point, which gave the patient a great sense of accomplishment and a kind of sense of normalcy. RT was there, nursing was essential for line management, pre-medication. And at one point, once his bed to chair transfers were looking good, they were doing some of the mobility. Again, perfusion was instrumental in getting this patient mobile and in the hallway. So our sessions were really dependent on their availability. And then we had the physician for continued parameters. And then his family was super engaged. So where we weren't able to do a lot of therapeutic exercise because we didn't have the time or stretching, the family was on board with helping him when he was able. So what would we do differently looking back at this case? I think the biggest thing would have been physical therapy sooner. There was that period of time that the patient was stable from end of May to June to PT evaluation, where I think we could have been really instrumental in starting to deal with some of this tightness, get a multi-POTUS boot on him sooner, do some delirium prevention and education. So when we did get to that point of being able to mobilize, we were in a much better place range of motion wise. Also even being involved with the prone positioning to help with, again, muscular tightness and skin. I think a schedule development would have been great. However, where we don't have a set perfusionist per unit, we really weren't able to set a schedule, but probably would have helped him with his anxiety, knowing what was coming up next. And then having a more liberal physician-driven protocol than our protocol that we had established would have given us more autonomy in making decisions on progressing the patient. And that is something that we are now currently working on, where we may be seeing more of these ECMO-dependent patients. So in summary, the patient stayed in the hospital in the ICU for 132 days. On ECMO for 130 of those. It was 79 days, almost 80 to PT evaluation, again, which is a pretty extensive period of time. But with his medical management and with his functional status, we did get him accepted to New York Presbyterian's lung transplantation program on August 11th, and then he transferred over there on August 14th. We did get an update from his family pretty much a week after he transferred over there, and he had made significant improvement, walking 300 feet with a rolling walker and was waiting for lungs. Very much unfortunately and sadly for all of us, as we were all very attached to this gentleman, that shortly after he transferred over to New York Presbyterian, he developed air in his ECMO cannulas, and the team apparently was unable to recannulate fast enough, and the patient expired. This is a really common complication of prolonged ECMO, and for someone who's been on ECMO as long as he did, he was at a very high risk of this happening. It was all very unfortunate. But in summary, prolonged immobility and medical instability requiring mechanical ventilation and ECMO contributed to significant ICU-acquired weakness and poor functional status. And our barriers to treatment were anxiety, a time-consuming nature of the session, the focus on functional status, and his medical status, of course. So now I'd like to just open up the floor, William and I are happy to answer some questions, but some things that might be helpful to kind of think about are the commonalities between these two cases, and maybe some cases you're currently seeing, as well as are you seeing some similar impairments, similar barriers to intervention, and are you using some similar strategies?
Awesome. Thank you, Christina and William. Thank you for the wonderful presentation. Now we'll open up for questions. So there is a few-minute delay between the Zoom and YouTube. So we'll give them some time to, I guess, think about some questions. And for the listening members, audience, as I had mentioned at the beginning of the talk, there is a chat window at the right-hand corner of this YouTube screen where you can post your questions. And if you have any, if you're unable to do that, or you don't know how to do that, I believe there is a phone number on the invitation that you may have come across. You can call that number and you can ask them the question, and they should be able to. You can ask them you can tell them your questions, and we will take questions that way as well. Yeah, I think that's actually a good 5-minute delay. The screen just changed from yours to mine. Okay. I think we'll wait for them to come up with some questions. Meanwhile, I think some of the things that even I needed some clarification on. Perhaps I'll ask some of my questions first. So when you're seeing these complex patients, I guess just based on your observation, right? Do you think that the percentage of these patients are the same, or do you think that sort of lessened these kind of complex patients that ended up being in the ICU, a lot of morbidities and mortality, just based on your observation, anecdotal evidence? Because there's a lot of talk about how it's slowing down and may not be as virulent as before. So just based on your observation.
Do you have any thoughts, Will? As far as their functional status post-discharge, or just as far as the number of cases that we're seeing?
Yeah, I would imagine the number of cases are probably low, maybe because the incidence has decreased, or the rate at which they're getting admitted to the hospital has decreased, but the percentage of patients who end up becoming severe, do you feel that has changed? Or I don't know if you will have the entire picture to say that, but just based on your observation, even the people who come to the ICU are not as sick as they were. Functionally, they're not as bad as they were.
Yeah, I would say, as far as it's difficult to say, just because the number of cases has dropped. So it's hard to speak to, is it just the instance that's low or the severity that's less? But I mean, at one point, all of our ICUs were completely full of patients who were vented and on ECMO and proned. And as of a week or two ago, we only had one person in our ECMO unit that was in that critical of a condition. So we went from every single ICU being full of these patients to the one that I saw a week or so ago. So again, it's hard to speak to whether that's just the number of instances that are lower or if the severity is less, but I think time will tell. And if a second wave ends up coming, you know, we'll be able to better determine that.
And as for the inpatient rehabilitation units, we were actually closed to make way for more medical beds for COVID patients. We opened up around late May in order to start admitting patients for inpatient rehabilitation. And we have a total of 50 beds between two units. And at that time, I would say well over 75% of the patients were what came in as post-COVID patients. And currently, we only have a handful out of the 50 beds who are considered post-COVID. And again, speaking to what Christina said, it's hard to say whether that's just a lower level of an incidence or severity, but it seems to be incidence at this time.
Got it. Understood. So I know, Christina, you had mentioned about prone positioning. So now they've started doing prone positioning even for awake patients. Is that something that you're involved with, or the physical therapist involved with, or is that something that just the nursing staff is able to do? And if it is something that you are involved with when patients are awake and you're putting them on prone, you know, just something practical that I have experienced as well. There seems to be some difficulty in what strategies could be used to help with that.
So we were at first, they started the prone positioning protocol. They did not include physical therapy. However, once we heard that this prone positioning team was occurring, we quickly decided that we wanted to jump on and at least provide some input for positioning, especially for shoulders and head and neck and things like that. Once we got involved with that, we did have some therapists that were on the prone team. And our goal was to, again, look at positioning, making sure we weren't hyperextending or hurting any joints, and also physically assisting with the prone maneuver. We were strictly consulted on those patients that were intubated, sedated in the ICU that were very much dependent for the prone transferring. We were not involved in the awake patient proning. So I can't really speak to that. I think that was more of a nursing driven protocol. But for the ICU dependent prone patient, we were involved. We tried to introduce a piece of equipment called the turtle or something like that. I can't remember off the top of my head, but we were mostly doing it manually with sheets. And then the physical therapy would be there checking the position and then making sure that there was a pressure relief team to tilt the patient's head every 2 hours also. So we started, again, in summary, we kind of started off not involved and then increased our involvement and then ultimately became part of the prone team, which was great, I think, pretty essential in making sure these patients didn't have any adverse events from proning.
Got it.
On some of the general medicine beds, it was for the COVID patients, proning was an intervention that the therapist would perform during their treatment sessions, depending on how well the patient was, how their oxygenation was, and whether or not they could tolerate proning, and if that assisted in increasing their oxygenation. So it was something they would work with on awake patients. in consultation with the nursing staff in order to make sure that once they were able to put the patient in prone, that the nursing staff was aware and that they would be able to assist the patient out of prone should that be necessary if the patient wasn't independent or became in distress while being in prone.
Got it. So some of the questions that I can think of when, because there are a couple of therapists who are working currently with COVID patients, but I would say not so much our therapist at from our rehab center, not so much in the ICU, but more on the medical floor, I would say. There's I guess there's only one ICU bed at the small hospital. But I guess the question that they had, again, this is from, a therapist in India. They were facing a lot of difficulty convincing the patients on the importance of active exercises, respiratory exercises. So is that something that you had faced as well when they're in the ICU or when they've just come out of the ICU into the medical floors? Patients are not very receptive, one, because they don't realize the importance of it, or they, just don't have the capability to do it. So on both of these scenarios, is that something that you have observed, and do you have any suggestions on how to overcome this? So they were more open to, just to add to that question, they were more open to passive respiratory exercises, but not active.
So I think something that we saw on the general medicine floors was something that was represented in both case studies. It's the anxiety that these patients had, that a lot of them felt like they were too fragile to move, and they were that fear of the oxygenation crashing when they performed functional mobility, on top of just feeling poorly, really diminished a lot of their compliance. So we would have to take it slow. We wouldn't coddle them with passive treatment. If they weren't willing or able to do functional mobility, then we would just have to see somebody else, because that was the most important thing that would help to get them better and moving and out of the hospital. And we made sure to educate them on that. And again, not coddle them, really, kind of have to take a firm hand in helping to improve their functional status.
Yeah, I would say completely. Yeah, I think especially with this one patient that we mentioned, he, again, very quickly would feel like he couldn't. Again, with the anxiety, with the thought of how challenging the activity was going to be, how he was going to feel short of breath, how it might hurt. So it was a lot of, we needed a lot of encouragement, but also kind of some tough love too, to say, if you want to get better, if you want to get back to those things that you enjoy doing, if you want to leave the hospital, you really need to participate in these activities, and pushing them. But again, like Will said, taking the time, making sure we were going slowly and at a pace that was more comfortable for them, but making sure that it was active and that they were participating.
Got it. Another question I think that would be of great help in understanding would be, back in, I think, May, when Teresa had done the presentation, we had asked her what was the protective gears that was the standard of care at that time when you're going to see that patient, when you're going to see the patients in the ICU, I guess to some extent in the medical floors as well. What is the standard of care now? Has anything changed since, I guess, May? More evidence has come up and said, well, probably a face shield and a mask, or any changes, or maybe they've recommended less, or any changes since that time. Anything new that is being different based on the evidence, because it keeps changing?
So the one thing that has changed is now with all patients, whether they're COVID positive or not, we are wearing safety glasses along with our mask. However, the PPE for seeing a COVID positive patient remains the same as it was in May, but with, I think the biggest change is the CDC has now recommended that there be a protective eye covering as well as the mask with all patients at this time. So once our patients, I'm assuming this is the case for Will also, once our patients were cleared from COVID and we're no longer testing positive for COVID, we were just utilizing just the eyeglasses and the face mask, the regular face mask.
Got it. Dr. Weinrock, did you have anything to add to that?
No, same on currently on inpatient rehabilitation. Like she said, we are using goggles as well as just the normal surgical mask for all patients. If a patient is on isolation, we of course also wear the contact isolation gown. If we have a patient who has suspected exposure or is for some reason being tested for COVID while they're on inpatient unit, they are immediately put in an isolation room and they are only allowed to be seen bedside and not be taken out into the hall until that has been cleared by infection control.
Understood. So one more question that, again, would be important for us to know is that, again, back in May, when we had this talk, respiratory, I guess these active respiratory exercises that we were talking about, and also the passive exercises that we had talked about, we were informed that they were being very cautious. Of course, not much evidence had come about, but because of whether it's aerosol, whether it's not, and how much of aerosol is it, wasn't very clear. But that's when they were looking into that. So those exercises were being done very, very cautiously. Anything has changed from that perspective, or now that we know we've come up with these strategies and this is what we're doing now. Any suggestions on that?
I would say as far as respiratory exercises being aerosolizing, I think that the precaution is still being taken. Any patient, whether they're COVID positive or not, if they're in the hallway, because exercise at one point was considered aerosolizing, is wearing just a regular face mask. And then of course, any COVID positive patient who's doing respiratory exercises, again, they're trying to be making sure that they're in a negative pressure room and that the therapist is taking the precautions with the PPE. But so I would say probably still taking the same precautions as what was discussed in May in the acute care side of things.
So, so the precautions are okay, but from a, I guess, strategy perspective, are we doing anything different now? Have we come up with new strategies to say, okay, well, we're going to be doing tele visits for these patients, or we do this from a distance, or anything new that is being done now? Anything different, or just?
I don't believe so. I feel like, especially from the physical therapy perspective, so much of the work that we do requires hands-on, in-person physical assistance, just in order to ensure the safety of the patient. And so, like Christina was saying, just maintaining all those PPE precautions that we had back in May, still how we're moving forward, I believe.
Got it. All right. Again, thank you for answering all the questions, Dr. Nosala, Dr. Weinrock. I think what has happened, I suspect, is that because things have started to open up. I mean, despite the fact that the number of cases continue to rise in India, things have started to go up, open up. I think we're not seeing too many live people today. However, I do suspect that there will be a lot of interest in watching the recorded video. And at that time, they may have further questions. So what I'm going to mention, what I'm going to let the audience know, whether they're watching now or watching later, the email and the phone number that you can contact. If you have any questions that come up now or come up later, you can just post those questions to that. You can email to the email address or call that phone number and ask your questions, and we will get the answers from the speakers and we will get back to you. So just wanted to let you know that. I'm assuming that should be okay with you as well, right?
Absolutely.
Yeah.
Okay. All right. Again, thank you very much. Truly appreciate you giving this talk. And I know for a fact there's going to be a lot more interest in the recorded video because we noticed the same pattern on day one as well. So appreciate your participation and answering all our questions.
Of course, you're welcome.
Thank you so much.
Thank you. Take care.
Bye.